Now, with this august audience, I don't really need to discuss what is HbA1c. We all know it's glycated hemoglobin derived from non-enzymatic addition of glucose to valine and lysine residues, and is a specific GHB that results from the attachment of glucose to the N-terminal valine of hemoglobin beta chain. That is why it has the words HbA1c. Now, total GHB includes all the glycated fractions comprising A1C as well as hemoglobin glycated at sites other than the N-terminus of beta chain. And it is reported as HbA1c has been used to monitor glycemic control in patients with diabetes for several years. Sample requirement is an EDTA sample, which is stable for 7 days at 2 to 8 degrees or 3 days at room temperature, and no sample preparation is required from patients. Now, just a quick word on what are the factors that affect HbA1c testing. Acute hypoglycemia, severe anemia, gestational diabetes, the lifespan of RBC. So if a person is suffering from hemolytic anemia, it affects the HbA1c. Abnormal hemoglobin like hemoglobinopathies, triglyceridemia, and the method of estimation. Now, the advantages of HbA1c. We all know it's an index of long-term control of over 120 days, and not like a snapshot glucose level estimation, can be done at any time of the day. It is not influenced by diet, exercise, or any other factor. It's an useful index in clinical trials, useful even if drugs are missed or there's a faulty diet, and in the differential diagnosis of stress hypoglycemia. But there are limitations of HbA1c. What are the limitations? It cannot be an emergency room test to titrate the levels of insulin or oral hypoglycemics. It cannot register hypoglycemia. It is more sensitive to sin than repentance. So if it is elevated, it confirms poor control. If it is borderline, it cannot assure good control in the recent past. And not sensitive enough in gestational diabetes. It is affected in anemia, uremia, and pregnancy. So what are the basic test methods of measuring A1C? And the reason why I'm discussing it is because there's a great variation in the different methods that are available to us today in the market. So we have an immunoassay method, we have an ion exchange chromatography, which most of the laboratories use today, which is called HPLC. We have boronate affinity, we have enzymatic assays, and we have the capillary electrophoresis method. Now, it is important for people to know, the clinicians to know, that hemoglobinopathies do affect and interfere with estimation of HbA1c. Now, all methods are inappropriate for assessment of glycemic control if there is an hemoglobinopathy. Now, this is just a quick chart which I've taken from the books to show which are the methods and which equipments cause interference and which don't. Can I have a laser, please? Laser pointer. Is it there? Yeah, okay. Yeah, thank you. So there are methods like the Abbott where there is interference. There are methods like date dimension and Beckman's methods where there is no interference. The ortho instrument of Vitros has no interference. So whenever you are asking for HbA1c, it is very important to know what method is used and whether there is going to be an interference of hemoglobinopathies when estimating HbA1c. Now, this is again some of the other methods, and Bio-Rad D10 and variant is the most popular method for estimating HbA1c in majority of the labs. And fortunately, it does not show any interference with hemoglobinopathies. However, there may be an abnormal band which may be seen when HbA1c is estimated, and it is important for the laboratory to draw the attention of the clinician that there is an abnormal band, and that should be looked at from patient point of view. Hence, it is important that we have harmonization of the different methods. The three major harmonization schemes are NGSP, that is National Glycohemoglobin Standardization Program, the scheme of Japanese Society and the Swedish Society, and all converge. All are showing considerable divergence in the HbA1c methods. Because there is a variation in the estimation of all these methods, which we have been following over the years, IFCC, that is International Federation of Clinical Chemistry and Laboratory Medicine from the US, got into and formed a working group of HbA1c standardization and developed an international reference system. They felt that there was a major need. Now, the basis of this was that whenever there was a method which was followed by any of the labs, which fell into either the Japanese method or the Swedish or the NGSP method, they found that there was a huge variation. So progress in the composition of the resins, this was developed by the Japanese and the Swedish to make sure, and they felt that by doing that, they would standardize the estimation of HbA1c. However, I will show you a slide where either HbA1c, HbA1, that is A1A, B, C, or total GHB, a single sample produced widely varying results among methods of laboratories, and hence it became very diffuse, confusing for the clinicians to treat a patient. For example, the mean result for each method for the CAP approved laboratories proficiency survey varied from 10.7% to 17.8%. And this made it impossible for physicians to relate to test results. So if a patient did the GHB at one lab, it may vary from 10 to 17, which is 70% variation. How is a clinician expected to treat a patient when there is so much variation? Hence the need for establishing a reference interval which was would differentiate normal from abnormal test results. Harmonization was based on calibration, on method comparison, and standardization by introduction of a reference system. So although there was an urgent need, there was no definitive reference method, and therefore the AACC, that is American Association of Clinical Chemistry, recommended a subcommittee for standardizing the HbA1c estimation. And when they did that, they had an epidemiology of diabetes intervention and complication, an IDEC study, and this showed long-term CVs of less than 3%. Means when you talk about CV, that means there is very little imprecision in the methods that are established. So whenever you find deviation in HbA1c which is not matching with what you expect, please ask the lab what is the CV percent or what is the precision level of the lab for HbA1c estimation, because that will give you a clue into the methodology that is followed and precision of the labs. Now the development of NGSP happened in 1994. The implementation of treatment goals was based on the results of the DCCT in clinical methods. So what happened is, in brief, they just showed that you had to have a central reference laboratory. There were multiple reference labs which converted into a central reference lab. They had calibration, certification, and proficiency testing. And this was administered and monitored by CAP. Now, if you look at it from 1993 to 2008, there was a lot of variation in the lab methodologies. These were calibrated NGSP certified labs, and gradually as we progressed to 2008, the variation reduced a great deal. So there was a standardization of methodologies that was established by NGSP. And the methods which did not follow the NGSP standards had a lot of variation. Then, of course, the Japanese thought that they had established standardized method. The Swedish standardization program thought they had established their own method. They did a lot of studies to show that their HPLC method was very good. But all major established manufacturers found that the reference methods for each of these programs, designated comparison methods, were not true or definitive for the reference method. And hence we come back to the IFCC, which is a measure and development of pure reference materials and a reference method. This is just, I'm not going to go into the technicalities, but HPLC mass spectrophotometry or HPLC and capillary electrophoresis were the two methods that IFCC actually measured and compared. 5 intercomparison studies was done by the IFCC network, the NGSP network of secondary reference laboratories, along with the Swedish and Japanese. Now look at the comparison of the network of NGSP versus IFCC, and you see that there is a huge variation. So they had to apply formulae that from IFCC to DCM, from DCM to IFCC. This is the NGSP, Japanese and Swedish. And formula had to be applied to make it a very standard method. And if you look at this, this is NGSP versus IFCC, which clearly shows that there is a bias between the two, which goes across all levels of HbA1c interpretation. Now, this is again to show you the clinical decision limits of various methods. And if you see, it varies from 4.67 and more than 8% for therapy to 3.45 and more than 6. How are clinicians supposed to treat patients? You have to know whether it's an NGSP method or an IFCC method, because there is a huge difference in the norms that have been established by both the methods. So the issue of reported results. Now, why is it important? NGSP gives you percentage of HbA1c, whereas IFCC tells you millimoles per mole. Again, there is a difference in the reference intervals and reference ranges, how you're supposed to do. Now, look at this. An NGSP result of 7.6% is equal to 6% on the IFCC scale. So unless you know as a clinician what is the reference range, if a person has done labs, and today we know patients do window shopping in labs, if they go from one lab to the other and if they're going to have a difference in the methodologies, you're going to not understand if you don't look whether it is NGSP or IFCC. So any conversion of results in routine practice from the current in issue could cause massive confusion amongst clinicians and patients. So this is where the ADA, the ESD, IDF in January 2004 discussed the issue of establishing current methodologies and reference intervals, and IFCC network as an NGSP anchor was established. Now IFCC is a secondary anchor. Unfortunately, no, I would say hardly any lab uses IFCC methodology of interpretation, and it is only NGSP methods which are used all across. We are used to percentage establishment. So unless and until we migrate universally and globally to the IFCC methods, we are not going to have a standard of reference or standard methodology of reporting. And unless ADA and AACC combine together to establish what we can do for patient management, it is going to be very difficult if you have patients doing two different methodologies. So as with any laboratory test, the result that does not fit the clinical picture should be investigated with and discussed with the clinician before the laboratory. I, being a laboratory person, have to be very clear that if the clinician says that it does not fit the management and I discuss my methodology, I have to look at the options. I have to discuss it with my clinician before we come to a conclusion when it comes to patient management. And therefore, there's a worldwide consensus that HbA1c should be reported in both NGSP as well as IFCC units by estimated average glucose, which may be millimoles per liter or milligram per DL. However, the decision on what to report is actually being made country by country. Now, when we select instruments, we have to remember what the instrument fulfills and what criteria NGSP versus IFCC. So whether icterus, lipemia, abnormal hemoglobins interfere, and what is the level of interference of the equipment, at what level does it interfere with interpretation, is what will help people to define which instrument to pick. Now, just a quick word on what are the new parameters apart from HbA1c which are coming into the market is glycated albumin. And I thought it would be befitting for me to tell you about glycated albumin. Is a test, reflects short-term glycemia, and is not influenced by situations that falsely alter A1c, which we saw in the first slide. So we have to look at glycated albumin. Fructosamine is another marker of glucose control and has not gained much popularity yet, but these are the markers which we will have to look at in the near future. We will have to have a lot of other parameters and equipments which will take care of the newer parameters apart from HbA1c, unless and until we don't have methodologies which standardize the NGSP and IFCC methods. Maybe we will have to migrate to either fructosamine or glycated albumin. Thank you very much.